Yeah.
Good evening, everyone. If you'd like to take your seats, we will get started here. My name is Jasper Dent, and I'm the events coordinator at McNally Robinson Booksellers here in Saskatoon. This event is being held on Treaty 6 territory, the traditional lands of the Cree, Saulteaux, Dene, Dakota, Lakota, and Nakota, and the homeland of the Métis. Thank you all so much for joining us tonight. Just to note that this event is being live streamed, so just please be mindful of the webcam to your right here. I'd also like to take this moment to encourage you all to silence your phones. Finally, during the Q&A portion at the end of this event, I will have a microphone that I'll take around to anyone who wishes to ask questions. I know not everyone likes speaking into them, but we just really appreciate it for anyone who might be hard of hearing or anyone who's watching online and maybe can't pick up those questions as easily. It's my pleasure to welcome you to the Saskatoon launch of The Medicine Chest, A Physician's Journey Towards a Reconciliation by Dr. Jarol Boan. Thank you to Dr. Boan for being here tonight and for working with us to create this event. And to get us started, Ian McLeod is going to come up and say a few words about how this book came to be. Everybody please give him a warm welcome.
Okay, I think we're fine. So we were in the restaurant before this event, and we were trying to decide what Jarol could focus on, and I don't think we made any progress on that. Had some ideas about what you wanted to cover, and one of the topics was, who is Jarol Boan? I just figured out that we started playing in the orchestra together in Regina in the fall of 1966. How do you like that? So old. And we went to the movies together in about 1970. And then she came and she had this crazy car. She was in residency at Foothills Hospital in Calgary, and she had Chrysler Imperium. That was about 16 feet long. And that's about the last time that we were closely in touch, because she went to the United States and spent much of her professional career in the United States working in clinics, working in inner city environments, and teaching in universities. So she had a broad range of experience in the medical profession. And then, because she had always probably been telling people at dinner parties how fabulous the Canadian healthcare system was, she decided to come back to Canada and actually work in the Canadian healthcare system. And that was in 2011, I believe. And, you know, she brought a unique perspective because she had reached the highest level of her profession in the United States. And she came back here with all of that professional knowledge, and also that, you know, doctor's insights, and was able to put it to work immediately in Regina and in the rural areas of Saskatchewan. And how this book came to be is something that Jarol is going to talk about, but she called me one day and said, I want to write a book, but I don't know how to do it. So over the next 3 years or so, I was on the other end of the phone while she was saying, well, I don't know if this book's going to be any good, and I don't know if I should write this book. So she did, and I would say that the big challenge in terms of my advice was to find a pathway where Jarol could present the issues, which are profound, in a way that was accessible and would really speak to a broad audience in Saskatchewan, especially in Saskatchewan and in Canada. So that's where I'm going to leave it. It's up to you.
Thank you. Well, there, I got it. I think I got it. Yeah. My name's Jarol Boan. I am a University of Saskatchewan graduate. Went to medical school here in Saskatoon. And they have a program, but I'm from Regina. That's where he was talking about going to the movies. And they have started a program where we could do our final year and live in Regina. So I finished off my career in Regina. But I don't know how many of you grew up here in Saskatchewan, but in those days, and it may be still true, that when you grow up here and you hear about other things around the world, you want to leave Saskatchewan because you want to experience some of those things in other places. So that's what I did. And when I came back in 2011 to move back to my hometown and experience the warmth and community of Saskatchewan, I started seeing in the hospital and in the outpatient setting a lot of chronic disease. And the chronic disease was happening in more Indigenous patients than I was used to seeing. Now, in the United States, I have worked inner city. I have worked in hospitals with a lot of what we call social determinants of health issues. And I have not seen the level of chronic disease that I was seeing in Saskatchewan. And I started asking the question, but if we have a publicly funded healthcare system where everyone has access, why am I seeing so much end-stage disease in this population? So that got me involved in a process of learning, stumbling through many experiences to learn about colonization and the effects of colonization. And that introduced me to some other doctors that were interested in this. And we started a program called Wellness Wheel, where we went out to reserve. And that gave me the context of where these patients were coming from. And as you know, there's a lot of fluidity between reserve and city. So people move into the city, and they go back to reserve, and they go into the city. So but it really helped me to see the reserve and get to know that community. So we would drive out 2 hours in the car, go to the health clinic on reserve, interact with the social worker, the community worker, the diabetic educator, as we solve problems together to try and prevent some of these diseases that we were seeing. And then we get in the car and drive back. And then the next week, another doctor would go out or I'd go out. It was a little bit haphazard at the beginning. It's now much more solidified and organized. And we started developing trust in the community. And then the word would get out, oh, the doctors are here. And people would just start coming to the clinic. So you really felt like you were doing something and helping people that didn't have access in other ways. That being said, there are physicians, rural physicians, in different communities, so they do have access, but sometimes there are transportation issues, or there are appointment issues, or a lot of times, sometimes, if somebody has an appointment in the city, our nurse would call, but the cell phone wasn't working of the person we were trying to call. So then, because we had the relationships with the community health worker, we'd call the community health worker, and she would go to that person's house on reserve and remind them that they had an appointment the next day. So the patient would show up for the appointment. It was really a matter of working with the community to get the whole system working. As I started to think about this process, I was really struck by some of the stories that I was told by my patients. I started sort of writing them down in a little notebook of what I was learning. And as I worked with Ian, we decided to put these stories into a composite. So somebody who had a difficulty with alcohol, for example. That could be several different patients all rolled into one, and that's the patient you'll meet in one of the chapters. It's not a real patient, but it is a patient that represents some of the things that I was seeing. And then weaving in some of the policy issues and some of the background treaty issues so that the patient is teaching me and therefore teaching you as you read the book about how these things all fit together. And I go through a very naive beginning to an end where I think there's a hope for the future. I think I'd like to ask people if they would like to ask me questions about what I might be able to answer. Because I don't know where to go. I could talk for a long time about social determinants of health, uh, adverse childhood experiences, about residential schools, about intergenerational trauma. I could talk for a long time, but I'd actually like to hear what you're interested in hearing about in terms of what brought you here, other than the fact that some of you may know me. So that's why you're here. But if you actually came to learn about the book, what brought you here and why are you interested in this area? Do I take now we've lost our little man that manages the, so
Well, I have a question.
yes.
So you said that you noticed a very high incidence of these chronic conditions. Could you name top three causes, or is it a much more multidimensional kind of a thing?
Well, one of the things that I get into in the diabetes section actually is about genetics. And so
Right.
sometimes you're born with a genetic profile that gives you a propensity to have a disease. But we do know that there are some very famous studies that have been done in the Pima Indians, actually, in the States. And there's a group of Pima Indians in Mexico who are genetically identical to the ones in the United States, in Arizona. And so researchers went there and studied both populations. The expression of diabetes in the Mexican ones was much lower than the American. And they compared what were the factors where the genes were expressed. And a lot of it had to do with diet and exercise. And that's where a lot of the treatment protocols that we have for diabetes are related to what can we do if you have the genetic propensity, what can we do to modify the genes from expressing themselves? So one cause is genetic. Another cause I think has to do with, and this gets into more of the social aspects, there's a very big distrust of the medical system. Understandably so, because I go into in the book the history of Indian hospitals where there was complete segregation. And experimentation. I talk about OCAP, where the communities own the data now, and you can't experiment on people anymore. So distrust, I think, would be number two. And number three, you asked for three. I tell a story in the book about how the fight or flight response is initiated. So if you're in a scary situation, you have the tendency to want to run away from that situation. And I don't want to, and I'm not in a position to talk about residential school trauma, but if you're constantly being barraged by trauma around you and you're experiencing trauma every day because of family circumstances, society circumstances, it can kind of get ingrained and be very difficult for you to trust and to access the medical system or to take care of the things that need to be taken care of, like getting to the doctor when you have a doctor's appointment. So, I think a lot of things go missed. Some of the chapters I deal with are hepatitis C and HIV, and our HIV rate in Saskatchewan is the highest in Canada, and is higher than some countries in Africa. And all of our new HIV cases in Saskatchewan, 80% of them are Indigenous. So we have treatment for HIV. We're taking the WHO 90-90-90 criteria to implement treatment, but that requires that you have relationships on reserve, you have trust, people are compliant. There's a lot of issues to making sure that people get the right treatment. You have a microphone?
We have no batteries. That's what I was trying to find.
No batteries. Well,
So-
I can repeat the question. Oh, there we are.
Yes. Okay.
Okay.
Who has a question?
Okay, well, I'll add to my
Yes,
original one.
yes.
I'm not.
You can talk the whole time, Marie.
Okay. So you said you remain hopeful, or you finish the book on a hopeful note. After hearing what you just said, tell me how that's possible.
There are 94 calls, TRC calls to action. 9 of them are in the healthcare field. I recommend that everybody take one and work on it. Reflect on what you can do to make a difference, and challenge your own assumptions. Some of the hopeful things that I see working are a process of self-government, which is outside the medical. It sort of is medical, but there's the process of self-government is more judicial than it is medical. But we have, for example, we have a clinical dietitian that works on reserve who's involved the community in building grow gardens. So they have fresh fruits and vegetables. I describe in the book, because we go to the corner store on reserve and it's pop and chips. And now through this process of involving community and growing their own gardens, they used to do that before colonialization, grow gardens, do hunting and gathering. And a lot of those skills have been lost. So now we're reestablishing those types of skills. I spent some time on a Tatapoop where they have a really, really robust Indigenous-led harm reduction program where ceremony is used and spirituality and connection to the land is used, so that it's a completely different than the traditional harm reduction program, but very effective. I see more medical students, nurses, educators coming into our universities and getting education and getting trained and then going back to the communities and giving back to those communities. So those are some examples. There are also examples of systems that have worked very well. The NUCA system in southeastern Alaska has a whole medical system. They run the hospital, they hire the doctors, they have all the services, and it's all Indigenous run. It's used as the example of a healthcare system that can be Indigenous run. We have other examples that I won't go into detail, but I do in the book.
Hi, the title of your book, The Medicine Chest, and when I read the little bit of the description of the book, it talks, I sort of got the feeling that you might talk a little bit about
Thank you.
Indigenous medicines too, like their own, you know, the original ways they had of healing themselves.
I do get into that. And thank you for bringing up the medicine chest. The medicine chest was a clause that was put in when Treaty 6 was negotiated in 1876. It was not part of the original typed treaties that the chiefs signed at the time of signing, but it was written in by Alexander Morris. There will be a medicine chest. And that then became, and the reason that those chiefs in Treaty 6 wanted it was because they saw starvation. And they saw that the white settlers who had settled around them there was a doctor on horseback with a little black bag, and they saw that chest and they wanted to have that chest. So they put in that clause. The evolution of that to across Canada, and the treaties were signed by the Crown. So across Canada, it's a federal mandate to have healthcare provided. I do get into in two ways. I have a chapter called Ceremony and Sweetgrass, where I talk about some of the things that I learned of people on reserve using the medicine the traditional medicine that they came from the elders and the knowledge keepers. I also get into, in another chapter, I get into some of the spirituality, because the one thing that I did learn from reading, from my experiences and getting to know my patients, is there's a very circular way of thinking. We can call it the medicine wheel, where there's a more holistic approach, and land and spirit and weather and everything ties together so that you have a more spiritual perspective. And that's not something that we usually teach in our medical schools. We grow up as physicians to be very linear, and we use data to save lives. So if your blood test is abnormal, I can interpret your blood test and I can tell you what we're going to do next. If that x-ray is abnormal, it's very linear and we use the data. But then when you go on reserve, or when you're with your Indigenous patients, there's a circular way of thinking and a circular way of explaining things, and the incorporation of more of a spiritual view of health and of medicine. And I don't know you, but are you experienced in these things?
No, actually, the reason I'm here is because I am learning, and myself and my friend took a course a few years ago called Unwinding Whiteness. And part of that course was taking advantage of every opportunity we could to learn more and become, you know, just more aware of our own privilege and colonization of this country and so on. So that's why we're here. We're not, well, actually, Mars is a nurse, so yes.
Well, thank you for coming. There's a question here and a question at the back.
Thanks for coming out. Well, I graduated in 1964, so I've been around quite a while. I got fired 20 years ago for old age by the university. But anyway, COVID hasn't been real good, except I learned a lot about insulin. And frankly, I will be giving a talk on insulin for the highlights in medicine,
Oh, yeah.
which is one of our biggest enemies. I'm very proud of Fred Banting for developing insulin, but 95% of people have too much insulin, and that especially probably applies to the First Nation population. And insulin, hyperinsulinemia is killing the population and killing the health systems. And if you go back, several years ago, I was talking to an older physician that had worked at a reservation near Dauphin, Manitoba, and he said we hardly ever saw any cases of diabetes at that time. And now it's not just a matter of having diabetes, but it's estimated 85% of the US population have hyperinsulinemia. That's high levels of insulin.
I know.
And it's related to our diet, especially fructose. Fructose is basically handled by the body exactly as is alcohol, except about 10% of the alcohol goes to your brain. And all this food that we eat is full of high fructose corn syrup. And it's a disaster. It's an absolute disaster. And it's not just with the First Nations. I every afternoon go and have a walk at Market Mall, and I have a cup of coffee at the Coachman. I see people go by. And you can, just by looking at it, you can tell they got a high level of insulin and have problems with about 10 different illnesses, such as the metabolic syndrome and any other thing. Sorry to intervene, but I'm just saying it. The question is, what are we going to do about this high level of insulin? What we do is these patients have come in with problems, and
Yeah, I understand. I understand where you're going.
Yeah.
They're
not educated.
Yeah. If I was going to take the approach that I've learned from my book, I would say we need to be more embrace humility and learn from the people that came before us. I'm just going to leave it there because I spent a lot in the book on insulin. So there's a question at the back.
In the early days of the vaccination for COVID, there was a two-tier policy where Southern Saskatchewan was still vaccinating 90-year-olds and up in the nursing homes. And in Northern Saskatchewan, the policy was 50 and up were being vaccinated at the same time. And I wonder how this impacted the sentiment of the Indigenous populations of having that reverse discrimination put in place for them.
That actually there was a different policy for Indigenous people in Southern Saskatchewan, and the vaccines went to reserve and were administered as the reserve decided to administer them. That's not publicized, but we were involved in it, so you probably aren't aware of it.
I remember at one time, just because I have relatives in Green Lake, there was an actual blockade on the highway restricting transit and checking people on the way.
Yeah.
Did you have any knowledge of what impact that had on the Indigenous populations?
We decided that we had to write a chapter on COVID in my book because it happened while I was writing the book. So I couldn't really eliminate it. And it may be out of date sometime because who knows what COVID's going to do, transform into something else, who knows. But So I had to really, I was actually on the provincial COVID team. And learned really a lot about how our healthcare system works from being on the provincial team. And I had to decide for our Indigenous peoples, how was I going to approach the whole aspect of COVID? And one of the things that happened with COVID was an increase in suicide and an increase in homelessness. And so I focused mainly on that in the COVID chapter, but I have a whole other chapter that's not in the book that talks about COVID that got cut from the book. So we can talk about that. I've been thinking I should revive that original first draft and put it into a paper to publish, because there were some things that I learned from our system. But when you write a book like this, you have to be really careful of what's the narrative, what each patient in each chapter will teach you something, as they taught me. And so you have to be really careful how much you bore your audience with extraneous things. And so some things got cut.
Hello, I was wondering if you could speak briefly about some of the ways that you used to build trust in the communities when you were working on reserve and off reserve with First Nations communities.
Yeah, actually, somebody last week asked me the question, how do you build trust when you're in a busy emergency room and you only have a few minutes? And my answer to that is sometimes you don't. I have a story in my book where I meet a patient in the emergency room and she is under a sheet. And I come in, I introduce myself, and she doesn't, I know she's breathing because I can see the sheet going up and down, but she won't talk to me. So I go and I write admission orders when I go back the next day. And the next day she kind of lowers the one corner of the sheet. And then the next day, so the story goes on. So sometimes you don't. But I think that, and I go back to this because I teach in the medical school, every physician cares. We go into medicine because we care and we want to help people. And it's a matter of making sure you can communicate that caring and make it real for people. It's a communication skill, as well as being able to look at yourself. So how do you develop trust? And sometimes you don't. I mean, there are people that don't like me. There are people that don't trust me. I can't. But I hope that I'm making a difference in the people that do.
Thank you for being here tonight. When you take on this feat of deciding to write a book and getting through to the last page and now seeing it here on a shelf, what has changed for you as an author in terms of the motivations behind the book? What do you want the reader to leave with? What's the driving force?
Well, the feedback that I've gotten from people in the community is that there aren't a lot of books that are written from a settler perspective that talk about understanding treaty, being in treaty, knowing how to. So I think this is just one tool in many tools on the process of reconciliation. From my personal point of view, I have to say, I talked to somebody not Ian, but I talked to somebody who was in the publishing business. And I said, oh, my book is finished. I'm so happy. I got to the last page. I'm really proud of the way it looks. I'm going to get it published. And she said to me, well, once you finish the book, now the work becomes harder. Now you're going to have to start really working. I don't want any more work. I've already done all this work on putting this together. So the whole idea of getting the book out to people's hands is another. I have a publisher, and they have a whole marketing department, and they're helping. And there's events like this. But what do I hope? I hope that people learn something and can follow a path of reconciliation. And that's the reason I wrote it, because I'm an educator. I'd like people to learn things, and maybe people can learn from the mistakes I made along the way.
Hi, thanks for coming tonight and giving us a talk. A question that I have about getting your book out into other hands. Have you thought, or have you already put your book in different reserves in the band office or in the health clinics and whatnot? I'm just thinking that, if some of the people on reserve, if they read your book, that might help with the trust because you understand them, or at least you're trying to understand them, and that might help in the building the trust and helping them to understand as well.
Yeah, be very helpful, I think. Thank you for that. I think there's another question up here. Yeah.
I was just thinking about audience, and the book is written from a Saskatchewan context, deals with treaties here in Western Canada. How broad an audience do you think it's for? Because this kind of settler incursions into Indigenous territory and so on has taken place in so many different places in the world.
Yes. Yeah. I don't want to have hubris or be arrogant, but I do think that there is a place for learning in many different cultures. I have some American friends, and when I told them the name of the title of the book. The response is, well, reconciliation, are you in marriage counseling? That's what reconciliation is. And so when I talk in the States with my American friends, I actually use the word reparations, because that's the Black Lives Matter, anti-racism terminology that's used. Hopefully that we don't have to change the title of the book to get sales in the US, because there will be people in the US that are interested. There's much more interest in Indigenous communities in the US now than there was even 10 years ago. So I hope I don't have to change the title. But it just goes to show that these issues are going on in all sorts of different cultures, of understanding another perspective on health and how a system can change, or how a little program like the little program we have in Southern Saskatchewan can make a difference.
Well, Gerald, did you write this book for the intent of the settler culture to read, and did you intend for the First Nations people to read it as well? How, and if you did, how would you be going about doing that?
I just want to mention Jim and I knew each other when I was in medical school here in Saskatoon, so we go back a long ways. Thanks, Jim. When I wrote it, did I have an audience? What do you,
Well, you wanted people, decision makers to.
decision makers, yes, yes, my advocacy. I want Scott Moe to read this book. He can't read. I mean, I really, I wanted to change policy because I think there are a number of places that our healthcare system has failed our Indigenous partners in this. So I wanted to make a difference. That was my motivation. Now, on reserve, I don't know if you guys know the book Clearing the Plains. Yeah. It was read by all the Indigenous communities. It's considered something that they take ownership in. Yes, there was their plains that was cleared. So they really liked the book. I had actually at the end of the writing, I had a sensitivity read done, which was very helpful to help with terminology because you can offend some people. So I'm hoping that I don't offend anyone with the terminology that I use in the book. But I think it would be helpful because I described some of the diseases. The other thing I described, which people have given feedback, is how our health system works. Because I'm in the hospital, I'm in a busy emergency room, or there's one story I have where I have to go and see, or I choose to go and see a patient after hours, after the emergency room. He's been moved upstairs to a bed upstairs, but I want to tell him the result of his scan. So I have to try and find him. And so I take the reader through going to the hospital floor at night and how different that is than the day, because most of you don't see a hospital at night. So I think it's helpful because there's various aspects of our healthcare system that give you the view that you wouldn't normally have unless you're in it. And I think the Indigenous people would enjoy that. I also, there's things like I talk about blood quotient and the controversy about blood quotient. I don't know if you know that terminology, but you need blood quotient to be able to prove that you're Indigenous, so you get the rights associated with that indigeneity. And I talk about a little bit of a controversy about that. And because in some ways it's, again, subjected to colonialism. So there's a little bit that is written for the Indigenous person, but I didn't write it for that reason. I wrote it because I want Scott Moe to read it.
Well, I guess there are Indigenous leaders now that are emerging in our society, and we can go to Manitoba, where Wakanoo is now the premier of the province. So will your book be helpful for him as a leader in the overall community, especially in the First Nations community, in being able to come to some place that's helpful to them through your book?
Yes. Can you get him to, you have his address?
I'll call him.
Yeah, call him for me. I saw him speak in Regina at the journalism, the Menifee lecture. He was the speaker at the Menifee lecture one year, probably about 10 years ago. So I saw him speak. He's gone places since then.
We probably have time for one more question. We're coming up on 8 o'clock here.
Oh, we got two.
You make two work.
Hello, Doctor. I will be a reader of your book, just wanted to mention. I also had a question about whether it will be available on Audible.
Yes, there's it's available on Kindle.
Okay.
Audible is when you, either the author reads the book or you get an actor to read your book for you. And I need a contract for that because I'm not gonna read the book. To people, I would fail terribly. I read or I listened to Audible of Prince Harry's book, Spare. And I was on an airplane and it's so fascinating. And I had finished writing this book at the time that book came out. And when I listened to him, the first thing I did when I got off the airplane was Google search who his coach was. Because he read his own book, but his reading was so good that I could tell that he'd had a reading coach to be able to do it. But so that area I'm learning a lot about publishing by going through this process. But that area of Audible is a whole other. It's like going to theater. You know, you can go to a music festival or you can go to theater. I mean, they're two different, in some ways, two different worlds, but similar. They're all in the arts, you know.
I had a second part to that. So I learned, I don't even know, it wasn't very long ago, I learned about ACE scores and the
Yeah.
correlation to illness. I know you never really got to speak to that, but I wondered if some of that was relevant in your writing.
Well, I'm just going to be really honest because I didn't want to get into talking about people who use drugs. I don't like to bring that up too much in public, but the ACE scores are very much part of this book. And there's a question right at the back.
You've had such a wonderful career to this point, and I'm sure you're still looking ahead at what's to come. I'm wondering if you have had what you would call your moment of triumph yet, and if it hasn't happened yet, what do you think it will be in the future?
The highlights of medicine. That's my triumph so far. Thank you.
I actually, you may know my brother. He actually just graduated from med school. He was at the U of R campus, but he went through the U of S, the program. He is his last little bit of residency and just spent some time up in La Ronge. And then before,
In family medicine?
yes,
Uh-huh.
in about 15 years ago, he was also a teacher in La Ronge before he entered med school. And I'll tell you, he just expressed to my brother and I how different and how much more difficult that community is dealing right now. And I think as a physician, he's gotten to see the other side of it. And so, in speaking with him, I'm not quite sure of you and as a student, but I think he would probably really appreciate reading this book as well. So,
Well, he may be part of what I'm doing with this book is all the royalties from this book are going to an award with the College of Medicine for Indigenous health. So he might be a candidate for getting the award because he sounds like he's already going on the path of learning by doing.
yeah, and it was a very difficult 6 weeks for him, but I think it was very good for him. So
I've heard really good things about the La Ronge program. I actually spent time there as a student myself. But I think things have changed for how many years, Jim? It's probably 30.
Remember.
Yeah, I can't remember. That's how old we are. Can't remember how long it was. Well, thank you very much, everyone, for coming out. Thank you.